Good morning, everyone, and good afternoon. Thank you for joining us today. My name is Marie-Claude Allard, and I'm the communication lead for CANUE. I would like to start by acknowledging that the Université de Montréal, where I work, is located on non-treaty Aboriginal territory. This land has long served as a site of meeting and exchange among Indigenous peoples. I wish to pay tribute to those who, since time immemorial, have been its traditional custodians. Before we get started, I would like to remind you to turn off your camera and stay on mute during the webinar. If you have questions during the presentations, please put them in the chat. Speakers will answer them as we go along. We will also save time at the end for Q&A. Also, the presentation will be recorded and sent to all registered participants after the webinar. This is the second of 3 introductory webinars in a project funded by the Federation of Canadian Municipalities Local Leadership for Climate Adaptation program. This initiative, which is led by CANUE and the Canadian Health Association for Sustainability and Equity, is focused on providing resources to local stakeholders to help them integrate health and health equity considerations into local climate adaptation plans. It's my pleasure to introduce you to our first speaker, Michael Lee. Dr. Lee is a senior scientist at the British Columbia Centre for Disease Control, specializing in environmental health research and surveillance. His work focuses on the connections between human, animal, and environmental health. His portfolio includes extreme heat, wildfire smoke, cyanobacteria, biotoxins, and other environmental health concerns.
Great. Thank you for that introduction. Let me pull up my slides here. Cool. Great. All right. My name is Michael Lee, and I am a senior scientist in environmental health services at the British Columbia Centre for Disease Control. And this afternoon, I'm going to be talking to you about the health risks associated with extreme heat and extreme heat events. And I'm going to be doing that through the context of work that we've done at the BC CDC to understand risk factors for mortality during the 2021 heat dome in British Columbia, Canada. So to start this presentation off in a good way, I thought I'd start with a land acknowledgement. And I respectfully acknowledge that I live, work, and play on the traditional, ancestral, and unceded territories of BC First Nations who have lived on and cared for these lands since time immemorial. And when doing this kind of climate change work, it's important to remember that extreme climate events like extreme heat events have disproportionate impacts on different communities and populations, including many Indigenous populations who live very closely with the land. So in the context of climate change, in which we're expecting to see more frequent and severe climate events like extreme heat events, it's important to build that into our work as we move forward so we can prevent those impacts from occurring. So here is an outline, an overview of the presentation I'm going to be giving to you over the next 30 minutes. I'm going to start with a review of what the 2021 heat dome was, and I'll talk about some of the early studies we did to understand what happened during that event. And then I will move on to talk about 3 specific studies that we've done at the BC CDC to understand individual risk factors that were associated with mortality during this event. And so you can follow along. The slides will be color-coded in the background according to these studies here. So what was the 2021 heat dome? You may have heard of this before, but this slide basically gives an overview of what the 2021 heat dome was. So this is a satellite image, a satellite-derived image of the heat dome in late June 2021, and it shows temperature anomalies at the surface. And you can see that although the 2021 heat dome affected large areas of the Pacific Northwest, it was really centered over British Columbia, and it affected pretty much the entirety of the province. And this was probably one of the most unprecedented and anomalous extreme heat events that's ever been recorded anywhere on the face of the Earth. During this event, we saw temperatures 10 to 15 degrees above seasonal norms, and national temperature records were shattered by a full 5 degrees Celsius. And one other important piece of context to understand about this event was that it occurred in late June, right during the summer solstice. So this means that we were receiving peak daylight hours. The days were the longest that they are at any time during the year, which had really important consequences for the accumulation of heat in the indoor environment. And I'll talk a bit more about that later in the presentation. So tragically, as a result of this extreme heat event in 2021, we saw population mortality across BC essentially double. So to demonstrate what happened, I'll walk you through these two different graphs. This blue line at the top, this shows the population weighted temperature across all of BC. And you can see temperatures began to climb around June 24th and 25th and peaked at nearly 40 degrees on average across the province on June 28th. This bottom plot shows the daily counts of all-cause mortality across BC, just slightly before the event through slightly after the event in early July. This black line across the tops of the bars shows our statistical estimate of expected daily mortality across the province. So this is a statistical model based on what we've seen during this time of year in previous years. And you can see that we expect to see about 100 deaths a day across BC. Now, the coloring of the bars indicates whether the daily count of mortality statistically exceeded what we expected based on this black line of expected mortality. And the excess mortality is the sum of all of these red and orange bars where we saw statistically significant excess mortality. And when you count up all those deaths, you can see that we saw 744 more deaths than expected during this 8-day time window coinciding with the heat dome. And one other important piece of context I want to point out here is that the peak in mortality occurred about a day after the peak in temperatures outside. So the hottest day of this event occurred on June 28th, but the peak in mortality occurred on June 29th, and that's likely due to the accumulation of indoor heat. And it's important to understand that the excess deaths that occurred were not equally distributed across age groups, and they weren't equally distributed across the community. So focusing first on these blue bars, we can see that there was about a doubling or 100% increase in mortality in every age group above 50 years old. Now, in absolute terms, this means that the largest number of deaths occurred in the age group above 85 years old, but it's important to remember that this age group is always at a higher risk of death. And so they always have a greater number of deaths than these other age groups. And when we think about it in terms of the percent increase in excess deaths, we see that doubling in every age group above 50 years old. So everybody in those age groups experienced very similar increases in their risk of death. Now, when we look at where deaths occurred, we can see that there were these modest increases in acute care and residential care settings, but the vast majority of heat-related deaths that occurred in the community. So these were deaths that occurred among people who died alone inside of homes without working air conditioning. Now, this graph really drives that point home as one of the most important takeaways from the 2021 heat dome, and that's people died because it was hot inside of their homes. So this shows 3 different temperature profiles. The blue line is the temperature inside a home in Abbotsford that had central air conditioning, and you can see that they experienced very steady temperatures throughout the entirety of the heat dome, whereas the red line is another house in Abbotsford that did not have air conditioning, and the black line is the temperature recorded outdoors at the Abbotsford International Airport. And you can see that the temperature inside the house without air conditioning really mirrored what was happening outdoors with 2 main caveats. So you can see in this house without air conditioning, the temperature only decreased by a few degrees overnight, while it increased quite a bit outdoors at the airport. It was still pretty hot outside for this time of year, but it cooled off much more outside than it did inside this house. And that's likely because this house didn't have adequate ventilation and it was heating up all day as the sun was glaring on it, which allowed those walls and the insulation and the other building materials to continue to reflect heat into the house later in the night. And that's why we see this second difference between the house without air conditioning and the outdoor environment, in that the peak of temperatures inside occurred 1 to 2 hours after it peaked in temperature outside. And this peak occurred right around 9 or 10 p.m., right when people are wrapping up their evenings and deciding to go to bed. Now, these background colors, the white, the yellow, and the orange, represent safe indoor temperatures that we have been working towards at the BC CDC and with other colleagues across Canada for safe indoor temperatures. White is considered, temperatures below 26 degrees are considered generally safe for everybody. Yellow temperatures are considered potentially unsafe for susceptible individuals. And then temperatures in the orange range are considered unsafe for susceptible individuals. And you can see that the house without air conditioning spent the entirety of the event in this potentially unsafe and definitely unsafe range. And it stayed in the potentially unsafe range into early July. And then finally, the deaths that we saw happen during this event were not equally distributed across our communities. So this heat map shows where some of the deaths were concentrated in Metro Vancouver during the heat dome. And in one of our earlier studies, Henderson et al. 2022, which is cited down here on the bottom, we found that neighborhoods with higher levels of material and social deprivation experienced greater risk of mortality, as well as communities with lower levels of green space. And that's likely because green space is associated with ambient cooling in the general area. So now I'm going to move on to talk about those 3 specific studies where we were trying to hone in on high-risk chronic conditions and other individual risk factors. So the first study that I'm going to talk about is what's called a case-only analysis, and here's the reference for it if you want to go look it up after this presentation. But the objective of this first study was to evaluate whether the risk of death increased for specific chronic diseases. And to get at this question, what we did is we compared the prevalence of chronic diseases among people who died during the heat dome to the prevalence of those same chronic conditions among people who died during what I'm calling here more typical summer weather. So the heat dome period in this study was defined as the 8-day period of excess mortality from June 25th to July 2nd, this period where we saw those statistically significant counts of excess mortality, the red and the orange bars in the top left panel here. And the typical weather period was defined as the same calendar dates, so from June 25th to July 2nd, but in the previous years, from 2012 to 2020, where we didn't see any impacts of extreme heat. And you can see from these graphs that there was little to no statistically significant excess mortality during these previous years. And we went back just far enough in time so that we had 4 comparator deaths for every heat dome death. And I won't spend too much time talking about the methods. I just put this here because this COVID-19 data library is really what enabled us to do this work. And this is essentially an online platform that enables us to link individual administrative health records for all of these different data sets that are collected in the province. In our first study here, we use what's called the chronic disease registries, which captures the incidence and prevalence of 26 different chronic diseases shown here on the right. Now, these aren't diagnoses of these diseases. They are based on individual patterns of healthcare usage, and there's a different case definition and inclusion criteria for each one of these conditions. So what did we find in this study? Well, I'll first direct you to this forest plot here on the right, which shows the odds ratios and 95% confidence intervals indicating the risk of disease, the risk of death associated with each of the diseases shown on the left. And we found that the risk increased significantly for schizophrenia, chronic kidney disease, and ischemic heart disease. But what was most striking and surprising about this study was how large of an increase in the risk we saw for people with schizophrenia compared to these other two conditions. So we saw nearly tripling in the risk of death for people with schizophrenia, while we only saw 36 and 18% increases for these other two conditions. And this was quite surprising at the time because while chronic kidney disease and ischemic heart disease are well recognized risk factors for dying during extreme hot weather, schizophrenia really wasn't on the radar for being an important risk factor. So it was quite surprising to see that the risk was so large for this particular condition. And that leads us to the question of, why did we see such a large increase for people with schizophrenia? Now, with this first study, we can't actually get at why these people experienced increased risks. We can only see that they did experience those increased risks. But the risk of death is likely driven by a complex set of interacting factors that come together in different ways for different individuals with schizophrenia. And I've shown some of those here on the right. So to list off four of the most important potential reasons that people with schizophrenia experience heightened risks. People with schizophrenia often have a condition called anosognosia. And anosognosia is when a person lacks insight into their own health status. So this may have meant that people were unable to perceive that they were overheating. And so they may not have taken actions to cool themselves down when they were in an overheating apartment or otherwise in their home. Second, people with schizophrenia are more likely to have other comorbidities that are associated with increased risks during extreme heat events, things like diabetes and substance use disorder. People with schizophrenia are also more likely to be socially isolated and economically marginalized. And finally, people with schizophrenia are prescribed antipsychotic medications, which have known impacts on the body's thermoregulatory capacity. And in the next two studies, we start getting into these specific risk factors a little bit more. So in the second study, we performed what's called a case control analysis. And again, the study is here if you want to look it up after this presentation. So the objective of this study was to, again, evaluate whether specific chronic diseases were associated with mortality during this extreme heat event. But here we also added the question of whether socioeconomic status was an important risk factor and whether socioeconomic status explained some of the risk that we saw for people with schizophrenia. And here what we did is we compared people who died during this extreme heat event with similar matched individuals who survived the event. Now, in this study, we were actually able to use an individual level measure of socioeconomic status. And that's important because most studies like this are relegated to using area or neighborhood level measures of socioeconomic status. But with access to the COVID-19 data library, we were able to see whether people were enrolled in this thing called Pharmacare Plan C. And this is a pharmacare plan for people in BC who have low income. And so people are automatically enrolled in this plan when they meet a certain income threshold with the Ministry of Social Development and Poverty Reduction. So what did we find in this study? Now, this forest plot is a little bit more complicated than the previous forest plot, but I'll walk you through it step by step. First of all, you can see that the two strongest risk factors in this study were indeed Pharmacare Plan C, so that measure of low income, and again, schizophrenia. But we also saw increased risks for several other conditions, including COPD, Parkinson's, heart failure, chronic kidney disease, ischemic stroke, and substance use disorder. Now, the next thing I want to draw your attention to here is the difference between the purple odds ratio and the blue square odds ratio. So the purple odds ratio is our model when we're adjusting for low-level income, and the blue square is the model when we're not adjusting for low-level income. So any differences between those two odds ratio implies that the adjustment for low income was explaining some of the risk associated with that condition. And you can see that when we adjust for low income, the odds ratio or the risk of death decreases for both schizophrenia and substance use disorder, which implies that low income explains some of the risk of death that we saw for people with schizophrenia and substance use disorder. So in summary, in this study, we found that Plan C, low income, and schizophrenia were the most strongly associated with the risk of death, as well as several other important conditions. But overall, low income was probably the biggest risk factor here, and it explained some of the risk associated with schizophrenia. And so in the third study here, we really wanted to drill down on that question of why people with schizophrenia were at a heightened risk of mortality. And in this study, we focused directly on trying to understand whether antipsychotics were associated with an increased risk of death. So here what we did is we compared antipsychotic dispensations among people with schizophrenia who died during the heat dome to people with schizophrenia who survived the heat dome. And while we were looking at the effect of medication, we also controlled for other important potential risk factors, things like schizophrenia disease severity, age, sex, and we broke the medications down into several different categories, which I'll talk about in a minute. So why were we so interested in antipsychotics? Well, antipsychotics are very important medications that are used to manage the psychosis associated with schizophrenia. And there are known side effects of antipsychotics related to the inhibition of the body's ability to sweat, and it can increase the body temperature at which cooling measures start. So there's biological plausibility here that antipsychotics were associated with an increased risk of death during this extreme heat event, but nobody's been able to look at this before. So in this study, we used a population-based case control, and that basically means that we compared antipsychotic dispensations among everyone with schizophrenia who died during the heat dome to everybody else in British Columbia with schizophrenia who survived the heat dome. So we're really looking at the entire population of people with schizophrenia in this study. So what did we find? First of all, we found that antipsychotic dispensations were indeed associated with a higher risk of death during the heat dome. You can see here that the odds ratio was nearly 2.5. So those who were dispensed an antipsychotic in the 30 days before the heat dome experienced about 2.5 times the odds of death than people who were not dispensed an antipsychotic. At the same time, we also found evidence that some of the risk associated with schizophrenia was explained again by things like low income, but also older age, being male, and measures of schizophrenia severity. So the number of emergency department visits for schizophrenia, and the longer a person has had the disease, so time since entry into those chronic disease registries. And then to drill down into this a little bit further, we broke down antipsychotic dispensations in a few different ways. First of all, here looking at equation 5, the non-grayed out area, we looked at the effect of individual drug dispensations, and we found that the risk of death was elevated for almost all of the antipsychotics that were commonly dispensed. But the risk was really driven by these top 3 drugs in the list shown here. And then we compared recent antipsychotic dispensations to continuous dispensations. So here we're comparing the risk of death for people who had been dispensed an antipsychotic in the 30 days before the event to people who had been dispensed an antipsychotic continuously over the previous year. And we could see that people who were more recently exposed to these antipsychotics experienced a greater risk than people who were continuously exposed to antipsychotics. So this implies that there's something about the drug being active in your system at the time that explains some of this risk. And then finally, we found that combination therapy was associated with a much greater risk than monotherapy. So basically, this means that people who were dispensed multiple antipsychotics simultaneously experienced a greater risk of death than people who were dispensed a single antipsychotic. Now, this might mean that um, combination therapies are often used for people with more severe schizophrenia. So that might explain some of this association here. But we also can't rule out the fact that being prescribed multiple antipsychotics may have been associated with more adverse side effects associated with impacts on thermoregulation or other adverse health effects. So in summary, in this final study, we found that antipsychotic dispensations were strongly associated with an increased risk of death. The effect of most antipsychotics that were dispensed were associated with an elevated risk of death, but it was really driven by 3 drugs. We found that recent exposure to antipsychotics and the dispensation of multiple antipsychotics was associated with an increased risk. And we found again that low income or Plan C was a strong risk factor. And then we also saw impacts of people being older, people being male, and these proxy measures of schizophrenia disease severity. So what are the implications of all of these findings about schizophrenia? So antipsychotic medications is indeed a risk factor, but at the same time, it's an extremely important component and potentially life-saving component of schizophrenia treatment. So we really can't make suggestions about changing treatments for this condition. But we did identify these other important risk factors, things like low income. And so this really highlights that we should be focusing our efforts on these other risk factors associated with mortality among people with schizophrenia. So, for example, Plan C indicates a need to focus on socioeconomic related factors and things like social isolation and lack of access to air conditioning. And we also found that clinicians in particular are well positioned to communicate these risks with patients about the risks of extreme heat. So more than half of the people with schizophrenia who died during this event had seen their physician for a schizophrenia related visit in the 30 days before the heat dome. And more than 80% were dispensed an antipsychotic during that time window. So this really highlights that if clinicians are aware of these risks, then they can communicate them to their patients and their family members. And one of the most important ways that we can prevent these deaths from occurring in the future of climate change, where we're expecting to see more frequent and severe extreme heat events, is to increase the frequency of health checks during hot weather. So if we know who is at risk in our social networks and in our neighborhoods, because of information like this, then we should check in on them during extreme hot weather to see if they have access to cool indoor air. And if they don't, maybe helping them find those cool indoor spaces. So just to summarize things here before I wrap the presentation up, the 2 most important risk factors that we saw across our studies were schizophrenia and poverty. So low income and schizophrenia were some of the biggest risk factors, regardless of what way we looked at the data. We also saw increased risks for several other conditions, including chronic obstructive pulmonary disease, Parkinson's disease, heart failure, chronic kidney disease, ischemic stroke, substance use disorder. And although I didn't talk about it in this study, we also saw an increasing risk of death for people who had multiple comorbidities, so multiple chronic diseases at the same time. And then we also saw increased risks at the neighborhood level for factors like material and social deprivation. So neighborhoods that had lower levels of education, lower income, and higher levels of social isolation. And then finally, we saw this impact of a lack of surrounding green space, which we know has important consequences for things like the urban heat island effect. So with that, I will end the presentation and thank everybody who contributed their data to this work and all of the teams in the background who really work together to make these sort of analyses possible by creating and maintaining that COVID-19 data library.
Thank you, Dr. Lee, for your great presentation. And now I would like to introduce you to our second speaker. Dr. Doiron is the managing director of CANUE and an assistant professor at the University of Montreal's Department of Environmental and Occupational Health.
Thank you, Marie-Claude. So thanks everyone for attending the session today. My section of this webinar will highlight how the Healthy Plan.City tool can be used by municipalities and public health authorities to prioritize areas for intervention in response to extreme heat. As extreme heat events become more frequent and more intense across Canadian cities, they also expose underlying inequities with certain neighborhoods and populations facing much greater risk than others, as Michael has just shown in his presentation. So this slide shows Healthy Plan.City screenshots from 10 different Canadian cities, each map displaying the spatial distribution of urban heat islands. And as you can see from the color contrast here, even within the same city, some areas are significantly hotter than others. The Healthy Plan.City tool helps make these patterns and underlying inequities visible by allowing users to explore extreme heat data alongside indicators such as income, age, race, and immigration status, providing a practical, evidence-based way to inform equitable climate adaptation planning. So for those who weren't at our previous webinar, I'll now give a very brief overview of the Healthy Plan.City tool. And if you have missed it, the first webinar is recorded and available on the CANUE website at canue.ca/climate-cities. So Healthy Plan is a free web-based tool that allows users to map demographic and environmental indicators in 129 municipalities across Canada. And within these municipalities, the tool allows users to explore the distribution of health-relevant environmental factors, such as heat islands, as we saw in the previous slide. The tool also allows overlaying demographic data with the environmental indicators to show a picture of environmental inequity in Canadian cities. And finally, Healthy Plan allows users to compare environmental inequity across similar sized cities and across neighborhoods within a given city. And finally, Healthy Plan really has two objectives in mind. Firstly, to support equity-focused decision-making in both public health and urban planning, and to empower community advocacy. This slide highlights the data that users can map in the tool. So in total, we have 13 different environmental indicators and 13 vulnerable populations or equity-deserving groups, which are all listed on this slide. Each of these variables can be mapped for 129 cities included in the tool. The environmental data that you see on the left here are derived from a variety of different sources, including satellite images and large open source geospatial databases, while the demographic data are all obtained from the Canadian Census. Finally, all data in Healthy Plan are nationally consistent, and they are indexed to each city block in the tool. Again, for more details on the tool itself, its functionalities and the data, you can watch the first webinar in this series, which we hosted in April. I'll now walk you through how Healthy Plan.City can support cities in identifying and prioritizing areas for adaptation to extreme heat, using the city of Winnipeg as an example. So over the past week, Winnipeg was the first city in Canada to receive a heat warning. On Monday of this week, temperatures in Winnipeg hit 35 degrees Celsius, breaking a 60 7-year-old record. That's about 16 degrees higher than the seasonal norm, which is a daytime high of 19 degrees Celsius for this time of year. And this early event signals a broader worsening trend. So historically, Winnipeg experiences about 14 days of above 30 degrees Celsius days. But by 2051, this number is projected to climb to 52 days per year. This is nearly 4 times higher than the historical average. And this rising trend in frequency of extreme heat events underscores the need for proactive place-based adaptation planning. Urban trees provide one of the most effective defenses against extreme heat, but Winnipeg's urban forest is facing multiple threats. So the city is home to approximately 200,000 American elm trees, which is the largest urban elm population in North America, but over 33,000 of them have been lost since 2016 due to the Dutch elm disease. The before and after picture that you see on the right here shows the dramatic impact of the Dutch elm disease has had on some neighborhoods in Winnipeg. And in addition to this recent loss of elm tree cover, ash trees, which make up 40% of Winnipeg's urban forests, are now at risk from the emerald ash borer. In other cities where this beetle has established itself, up to 99% of untreated ash trees have been lost within a decade. So the scale and speed of potential loss is alarming. And the impact of this tree loss is not just aesthetic or ecological, it's directly influencing neighborhood temperatures. Research has shown that in areas in Winnipeg that have lost significant canopy cover, they can expect to experience increases in surface temperature of up to 6 degrees Celsius compared to areas with stable or growing canopy. And this then intensifies as the urban heat island effect, particularly in residential areas with few remaining mature trees. As I'll show in the next couple slides, HealthyPlan.city helps visualize these intersecting risks by mapping urban heat exposure, tree canopy cover, and vulnerable population groups at the neighborhood scale. This then enables cities to target climate adaptation interventions such as tree planting, depaving, and shade infrastructure to the areas that need them the most. So in this slide, I'm showing the distribution of average summer temperature for the city of Winnipeg. The data you see on this map is obtained from Landsat satellite imagery and is the average land surface temperature between the months of May to September for the years 2019 to 2021. The data is then averaged for each city block included in the tool. This map then provides a general picture of the locations of heat islands and cooler areas in each city in HealthyPlan. As I'm showing here, clicking on a location provides the average summer temperature value for a given city block in degrees Celsius. And as you can see from the legend in the upper left here, red polygons indicate high summer temperature, while blue indicates relatively cooler areas. And we see that these are close to the river in Winnipeg. HealthyPlan also allows exploring distribution of demographic factors, as I mentioned. And to do so, we first need to select none under the built environment tab or drop-down menu. We can then select the demographic or vulnerable population indicator from the third drop-down menu. So here I show the variation in low-income individuals living alone, which is a group that is particularly vulnerable to the health impacts of extreme heat. Again, these data are available for each city block and each city included in HealthyPlan. And as with the average summer temperature layer I just showed, clicking on a city block provides the value for the selected city block, in this case, the percentage of low-income individuals living alone. As I mentioned earlier, these data are all obtained from the Canadian Census. So as I've shown in our previous webinar, which again is recorded and available on our website, the healthyplan.city tool allows users to identify areas where a relatively higher proportion of vulnerable or equity deserving individuals live in areas with less favorable environmental conditions. These areas are displayed in the tool in what we call equity priority maps. Here, I'll show you how these equity priority maps are generated using the two indicators that we just looked at individually. So with the low-income individuals living alone layer selected, I select average summer temperature, and this generates an equity priority map for this combination of factors. The city blocks that you see in yellow and red here are areas with relatively high average summer temperatures and high proportions of low-income individuals living alone. This map then provides a block-by-block view of where these two factors intersect, highlighting areas of greatest concern from an equity perspective. Clicking on the distribution tab on the top right here, we can quickly see how the value for both demographic and environmental indicators in a city block compares to all other city blocks in the selected municipality. And finally, the bar chart in the equity by the numbers window also allows comparing similar sized cities amongst themselves for a given combination of factors. So I can see that we are receiving questions in the chat, but before we get to these, I'd like to take a few minutes for you to try out the Healthy Plan tool in order to explore the distribution of heat islands in your community and how they intersect with vulnerable populations. So I'll ask you to open a new tab in your web browser and input healthyplan.city. You can then select your municipality from the first drop-down menu, and if your municipality or your community does not come up, try a large urban center that is closest to yours. The tool, I must note, is limited to municipalities with a population of 30,000 individuals or more. Once this is done, explore the average summer temperature data layer from your community. And to do this, you select it from the drop-down menu under Built Environment, and then set the vulnerable population drop-down menu to none. Once you've done these steps, take a couple minutes to explore the average summer temperature data layer for your city. You can zoom in and out to different neighborhoods and identify areas where average summer temperature are highest. So I'll give you a couple minutes to do this. Okay, so we'll go on to the next activity. So now that you've identified areas in your city most affected by extreme heat, let's explore who lives in these neighborhoods. So keeping the average summer temperature layer selected under Built Environment, turn on different vulnerable population layers to see how they overlap with the areas of high heat exposure you've identified in the previous activity. So we'll give you a few minutes to do this. Thank you. I'll pass it back to Marie-Claude now to close, and we can also we have a few minutes to answer some Q&A.
So thank you for answering these questions. This information will help us better tailor upcoming webinars and adapt the Healthy Plan tool to user needs. Kim Parada who is the executive director at Chase, will direct a few questions to our speakers based on what we entered in the chat. We have a couple of minutes, Kim.
Hi, it looks like there aren't a lot of questions today, but there is one from Abby Tobacco for Denis. Will there be plans to include smaller municipalities in the healthyplan.city tool?
Yeah, so that's the question that we often get. We decided to limit the tool to municipalities of 30,000 and over, simply because of the lack of variation in the data, both environmental indicators and demographic indicators that we often see in smaller communities. This then means that our equity mapping feature or functionality doesn't really apply, because if there's little or no variation in either demographic groups across the city or environmental indicators across the city, we're not that equity mapping feature is not possible. So to put it short, for the moment, there is not any plans to include smaller municipalities, but it's something that we can think of perhaps to just provide individual factors, and smaller municipalities being able to look at the distribution of individual factors rather than overlaying both demographic and environmental factors.
Thanks, Danny. One question here is there an opportunity to import data into the tool?
As it is, no. However, the architecture of the tool allows for this. It would require some web development resources. We have built it so that it's adaptable and we can import new data. But there is no plan at this moment to include additional data. We decided to limit the tool to data that is nationally consistent, so that we can have the same kind of analyses across different cities across Canada. So if you do, this being said, if you do have data that you think should be included in the tool, and that covers all of Canada, please reach out to us and we can see what we can do.
How are we for time, Marie-Claude? Do we have time for one more question or no?
We have 2 minutes to wrap up.
Okay. I guess if there is, as many of us in small towns know, there's inequity within our communities. The science and mapping helps us explain and address this. So I guess they're just saying it would be great to have a tool that would do that. I guess the question is that possible, or does the data not support that?
Like I said, what we saw in smaller communities, there is very little variation in many of the demographic factors that we include in the tool, if at all, any variation.
Okay.
Yeah, so that was one limitation in including these smaller towns.
Okay, so there's a few small questions which I'll let you answer in the chat and then pass things back to Marie-Claude. Thank you.
Sorry about that, but that's all the time we have. I would like to take the opportunity to thank everyone who joined us today on today's webinar. Your participation is greatly appreciated. We will offer one more introductory webinar on June 11th that is focused on flood risk. Looking forward, we will be running another series of webinars in the fall and winter 2026 that will showcase examples where municipalities have implemented measures that improve climate resilience while also improving health equity. If you know of an innovative climate adaptation project that has the potential to improve health and health equity, please send a note to Kim Perota at kim@chasecanada.org. So we hope to see you at our future events, and have a good day, everyone, and thank you.